3 ambulances arrive at once. The charge nurse calls a code mass casualty. Beds fill immediately. Chaos, voices, alarms, the hiss of oxygen regulators. I in the corner of trauma bay 2, a young nurse. Early 20s, first month insignia on her badge, stands still for 1 second. Just one, not lost. Observing an Admiral in navy dress blues enters with 2 operators. They came for 1 patient. Critical intel asset. That's not their priority anymore. 15 people need blood. Fluids. Intervention. The rookie moves toward trauma bay 4 where a patient is crashing. No hesitation. No panic. One of the operators leans to the Admiral. That's the new one. She's already calling labs. Already diverting a unit of ONEG. Already estimating time to intubation with the precision of someone who has done it hundreds of times. The Admiral's jaw tightens. They were wrong about her. St. Michael's ER, Tuesday night, 10:17 p.m. Sarah Chen had been a registered nurse for 31 days. She stood at the medication cart in Bay 7, counting 4 bags with the same systematic precision she'd used for 6 years in a different uniform. Label, lot number, expiration, hand position, 1 motion instead of 3. Muscle memory wasn't supposed to transfer like this. The muscle was muscle, and the brain was the brain, and you were supposed to be able to wall them off from each other. She couldn't. The charge nurse, Margaret, 17 years at St. Michael's, kind face, permanent exhaustion, had already written her off. Not maliciously, just the way of it. New graduate. First clinical. She'd probably last a year before burning out or moving to outpatient. They all did. Sarah, bed 3 needs a standard intake. Can you handle that? Margaret's tone was gentle. The tone you used for capable children. Yes, Sarah said. She didn't add anything. No enthusiasm. No self-doubt. No apology for her inexperience. Just affirmation. She'd learned in her last life that people mistook silence for acceptance. Bed 3 was an older woman, 60s, stable vitals, complained of chest pain for 8 hours. The woman was anxious, fingers working at the blanket, breath shallow. Sarah pulled the chair close and sat at eye level. Mrs. Patterson, I'm Sarah. I'm going to ask you some questions, and then we'll figure out what's happening. Does that work? Not rushed. Not condescending. Just clear. She took the history the way she'd been trained, the civilian way. When did it start? What were you doing? Any previous episodes? But underneath, she was also reading. Breathing pattern, anxiety-driven, not cardiac. Pupils, normal. Skin temperature, cool. Stress response. Capillary refill, good. And the way she held her left arm, protective, but not cardiac. The woman was having a panic attack on top of existing health anxiety. Real. Not nothing. But not what Mrs. Patterson thought it was. Sarah placed her hand on the woman's shoulder. Warm, grounded, still. Your heart is working fine. I know it doesn't feel that way right now, but I've checked. Everything is what we expect, Mrs. Patterson's breathing slowed. That's when Margaret appeared at the curtain, already moving toward the next task. She did a double take. In 30 seconds, Sarah had shifted Mrs. Patterson from crisis thinking to calm. No medication. No panic protocol. No explanation of every single test. Margaret's eyes narrowed slightly. Not suspicion. Noticing. Sarah continued with vitals, EKG, normal, blood sent to the lab. Charted it all in clinical language. By the numbers. Nothing personal. Nothing that would draw attention. She was moving through Bay 4 set up for a diabetic admission, when the call came through. Bay 9. Acute allergic reaction. ETA 2 minutes. The ER shifted. Everyone could feel the ladder going up 1 rung. Bay 9 was assigned to Rachel, a good nurse, 2 years in, quick but not careful. Sarah heard the ambulance doors open outside, heard the dispatch radio crackle, heard the controlled panic in the paramedic's voice. 42-year-old female, anaphylaxis, epinephrine already given in field, airway still patent, sats at 92 and dropping. She didn't think about it. Her body was already moving, muscle memory translating into present tense. She was grabbing the anaphylaxis kit, the second AP auto-injector, the 4 setup with 18-gauge and blood draw tubes, the antihistamine push dose. Not the standard arrangement. The efficient arrangement. The one that shaved seconds. Rachel looked at her, confused. I've got this, Sarah. First month. Maybe just help me get the monitor on. Sarah didn't argue. She set everything on the bedside table in order of use. Step back. Let Rachel lead. When the patient came through the doors, struggling to breathe, skin blotching, fingers swelling, Sarah watched Rachel freeze for 1 full second. That second cost them nothing. This time, Sarah had seen that freeze before. She recognized the cost of indecision. She moved the EpiPen closer to Rachel's hand and stepped back again, invisible. The first sign was the phone call to Margaret. Sarah was restocking the supply room when she heard it through the door. Margaret's voice shifting into a formal register she almost never used. Yes, sir. Understood. We'll prepare Bay 12. Private admitting corridor. No, that's fine. We have protocols for that. Bay 12 was the isolation ward, designed for biohazard cases. Equipped with its own intake room, separate from the main ER flow, Sarah continued counting gauze pads. Counted them anyway. One package was short. She made a note on the supply sheet. Organized behavior. Normal behavior. The kind of thing that meant she wasn't paying attention to things she shouldn't be paying attention to. She was paying attention. 11 minutes later, Margaret appeared at the supply room door. Sarah, I need you to help prep Bay 12. Don't discuss it with anyone, and don't answer questions if someone asks what you're doing. It wasn't a security briefing. It was exactly not a security briefing. The way you gave instructions when you wanted something done without it becoming a topic of conversation. Sarah nodded and followed her. Bay 12 sat at the end of a corridor that had only 2 entry points. Margaret unlocked the private intake door, the one used for psych holds and infectious disease patients. They began setting up the standard equipment: monitor for stand, oxygen delivery system, crash cart positioned but not visible from the doorway. Standard emergency admit, but elevated, Margaret said quietly. We treat him like any other patient, but we keep it quiet. We don't make notes outside the system. Anything unusual goes directly to me, not the board. Sarah didn't ask why. Asking why meant she didn't understand protocol. Understanding protocol meant she'd seen something like this before. They finished in 8 minutes to 11:34 p.m. 3 people entered through the private corridor. The first 2 were security. Not hospital security. Federal. The cut of their uniforms, the way they positioned themselves in a room, the tactical spacing. They didn't wear visible weapons inside the hospital, but Sarah could read the weight distribution. Trained operators. Not mercenary level, but solid. Combat experienced. The third was the Admiral. He was in dress blues, medals, insignia, the full formal display, which meant he was here in an official capacity and wanted it known. Tall, 60s, face carved from duty and decisions made alone at night. The kind of face that didn't show fatigue, which meant the fatigue was deeper than showing. Behind him came a patient on a gurney. Man in his 30s, restrained hands. Not hostile restraint, but controlled. Medical restraint. He was sedated, respiration shallow but controlled. No obvious trauma. No obvious illness. But his eyes moved even while sedated, tracking something internal. The Admiral stepped into Bay 12 without ceremony. He looked at the setup, nodded once. Turned to Margaret. No student nurses. No visitors. No one in this corridor without my authorization. Understood, sir. He didn't acknowledge Sarah's presence. She was furniture. Correct. She continued checking the crash cart supplies, every movement economical. Her hands were steady. Her breathing was steady. The muscle memory wasn't shaking. The Admiral's 2 security personnel positioned themselves, one outside Bay 12, one at the corridor entrance, both with sight lines to the main ER and the intake door. They had a communication system Sarah could almost hear, the way they looked at each other, the way their posture adjusted. They were waiting for something. Something they expected. The patient was rolled into Bay 12, and 4 was already in military field standard. The Admiral pulled a chair close to the bed and sat. Just sat. Watching, Sarah finished her inventory of the crash cart. She was about to leave when the Admiral spoke, not to her, but to his operative at the door. 2-hour window. If his condition changes, we move him to surgical holding. I want a secure perimeter by midnight. Midnight. 8 minutes from now. Sarah didn't know what that meant. That was correct. She shouldn't know, but she understood the language, understood the precision, understood that something was arriving at midnight, and this patient was part of a larger architecture she wasn't supposed to see. She left Bay 12 and returned to the main ER. Margaret was waiting near the central station, watching the clock. Everything all right? Margaret asked, but it wasn't a question about Sarah's capability. It was a question about whether Sarah had understood the implicit instruction. See nothing, say nothing. Yes, Sarah said. Bay 12 is prepped and stocked. Margaret nodded and turned back to the board. Sarah watched the clock. 11:45 p.m. 15 minutes until midnight 15 minutes until something changed. Midnight arrived quietly. Sarah was reviewing a patient chart in Bay 5 when she heard it. Not something loud, but something precise. A shift in radio traffic. The Admiral's operatives weren't using hospital comms. They had their own system. But she could read the timing. A message sent, a message confirmed. Exactly on schedule. She kept reading the chart. It was a standard admit. Diabetic crisis, controlled now, waiting on labs. She'd already done the intake, medical history, allergy screen, last medication times, family contacts. Clinical and complete. But she'd also done something else without thinking about it. She'd checked the room for exits, checked sight lines from the doorway, verified the crash cart had what she'd need if things went wrong in the wrong way. Not paranoia. Habit. By 12:07 a.m. The ER had settled into the rhythm of a Tuesday night at midnight. 4 beds occupied, 2 stable, 1 pain management, 1 waiting on labs. The charge nurse was at the central station doing charting. Rachel was in the break room. 1 resident was reviewing imaging in the conference room. The place had the suspended feeling of waiting, between the evening rush and whatever would come next. Sarah knew something was coming. She moved through the ER with routine purpose. Restocking carts, checking monitors, nothing that would draw attention. But as she moved, she was also noting. The Admiral's operative at the corridor entrance had shifted his stance twice in 5 minutes. Weight off his front leg, attention narrowing. He was expecting movement soon. She passed by the private corridor entrance, the one that led to Bay 12. She didn't look in. She didn't slow down. But she saw enough. The Admiral was still in the chair, still watching the patient, still waiting. At 12:19 a.m., an elderly man was brought in by his daughter. Fall at home, possible hip fracture, confused presentation, disoriented to time, trying to speak, but the words weren't connecting correctly. The daughter was frightened, hands shaking. He was fine 2 hours ago. I don't know what happened. He fell. I heard the fall. He hit his head, but he said it didn't hurt. Now he can't. He's not making sense. Margaret was overloaded. She assigned the patient to Sarah. Intake and basic neuro check. CT will be here in 20 minutes. The old man, Robert Carlson, 81, was frightened in the way elderly people are when their own mind is betraying them. Confused, embarrassed, reaching for stability that wasn't there. Sarah rolled the chair close. Sat eye level with him the way she'd done with Mrs. Patterson. Mr. Carlson, I'm Sarah. You fell at home. That's why you're here. Your daughter is right here. We're going to figure out what's happening. His eyes moved, tracking something that wasn't there. Sundowning, probably. Delirium from the fall. Maybe a small stroke. Maybe a bleed. Not immediately life-threatening, but time-sensitive. She took his vitals. Blood pressure 168/94. Heart rate 87. Respiration 16. Temperature 98.6. Fine. All fine. She did the neuro check the way she'd been trained. Asking his name, correct. Date, he said 1987. Location, he said hospital, then my mother's house. She asked him to follow her finger with his eyes. Tested grip strength bilaterally. Checked pupil response. But underneath that civilian assessment, she was also doing something else. She was reading his overall status the way a combat medic reads a patient in the field. Circulation, respiration, neurological deficit. Was he bleeding? Probably not. Pupils were equal and reactive. Was he in shock? No. Was he stable enough to wait for CT? Yes. Could he deteriorate rapidly? Yes. She was building a contingency plan for a man who probably just had a confused fall. That you're going to be okay, Mr. Carlson. I know this is scary, but you're safe. Your daughter is here. We're taking good care of you. She meant it. But she was also thinking, if he codes before CT, what's the quickest way to get him to imaging versus, or if he seizes, what's the medication sequence? If he bleeds internally, how much time do we have? Sarah, the old man's voice was small. Am I going to die? She didn't lie. She didn't offer false comfort. Not tonight. Not if we can help it. And we can help it. His daughter was watching her. Watching the way Sarah's hands were steady. Watching the way she spoke with certainty. Watching like maybe she'd found something solid to hold on to. Sarah finished the charting at 12:31 a.m. She clocked the time without meaning to. The Admiral's operative at the corridor entrance shifted his weight again. Relaxed, just slightly. Whatever he'd been waiting for at midnight had happened. The waiting had changed. Now they were waiting for something else. Sarah updated Margaret on Mr. Carlson's status and returned to the supply room to reorganize things that didn't need reorganizing. The ER was still calm, but the calm had teeth now. The call came through dispatch at 12:58 a.m. Sarah was in Bay 3, starting in 4 on a routine admission. 40-year-old male, chest pain ruled out, anxiety diagnosed, ready for discharge paperwork. She had the catheter in the basilic vein, securing the tape, when she heard the radio crackle and the dispatcher's voice change register. All units. Mass casualty incident reported at Brennan Industrial. Chemical spill. Hazmat responding. ETA to St. Michael's. First casualties 4 minutes. The hospital didn't pause. But everyone heard it. Sarah's hands kept moving. Tape, saline lock, label. One motion. She was thinking in layers now. Which patients were stable enough to discharge immediately? Which beds would need to be cleared? What triage category a chemical burn victim would need? She didn't let her hands shake. Margaret, we need to call it. That was Dr. Reeves, the senior resident on shift. Not a question, a statement of fact. Get the announcement out. Clear electives. Call in the team. Margaret was already on the phone. Her voice was still calm, but the words were routing protocol, code mass casualty. All available staff report to the ER. All scheduled discharges go to fast track. All stable admits hold in rooms. We have incoming chemical exposure incident. For minutes, the ER transformed in 30 seconds. Nurses moved from station to station, waking up. Residents appeared from the conference room. Respiratory therapy emerged from the back office. The surgical resident who'd been reviewing imaging abandoned his station. Everyone knew the protocol. Everyone moved. Sarah finished securing the 4 and stepped back from Bay 3. The patient watched her with sudden fear. What's happening? We have an emergency. You're safe. We're going to get you to a waiting area where you'll be comfortable, and we'll finish your paperwork when things settle down. She called for the discharge coordinator without raising her voice and moved toward the supply area. Around her, the ER was shedding its normal structure. The central station became command. Beds were being stripped. The medication cart was being inventoried by Rachel, who'd run drills before, but never a real one. The ambulance bays were opening. Sarah was pulling trauma packs, sterile field, dressing supplies, for equipment in organized sets, when she heard the first siren. Not distant. Close. Immediate. Then the second. Then the third. The dispatch radio kept going. First ambulance. ETA 90 seconds. 8 patients. Respiratory exposure. Chemical burns to exposed skin. Vitals stable but declining. Second ambulance. Margaret was calling assignments. Sarah, I need you in Trauma Bay 1 and 2. Get those set up first. Triage comes in cold. We don't have time for fine assessment. Anyone who can walk goes to fast track. Anyone who can't stays here. Sarah was already moving. She'd assessed her environment the way she used to in different circumstances. What was here? What was accessible? What could be requisitioned fast? She knew where the fluid warmers were. She knew how many cooling blankets the ER stocked. She knew that hypothermia would be a secondary concern if the chemical burns were deep enough. Trauma Bay 1 first. Monitor. Crash cart. Oxygen delivery at high flow ready. Suction. 2-4 stands. She grabbed trauma packs and opened them, laying out supplies in the sequence they'd be used. Gloves, multiple sizes. Gowns. Face shields. Not because she was being cautious. Because triage was coming in soaking wet, potentially contaminated, and anyone who touched them without protection would be secondary casualties. She was in Trauma Bay 2, setting up the second station, when the first ambulance doors opened outside. She could hear it from inside the hospital, the paramedics' voice tight and controlled. Multiple chemical exposure, Brennan facility explosion. We have 8 patients, for critical respiratory, for moderate skin burns. First patient, male, 40s, stridor present, respiratory compromise. The doors burst open. Margaret froze for exactly 3 seconds. Sarah could see it. The moment the charge nurse with 17 years of experience confronted something beyond standard ER chaos. 15 patients incoming. Maybe more. 2 trauma bays. 1 attending. One resident. 3 seconds of still water before the current swept everything forward. Sarah was already at Trauma Bay 1 doorway. I'm ready, she said. Margaret's eyes met hers for one instant. Gratitude, assessment, and something else. Recognition, maybe, that Sarah wasn't panicking. The first gurney came through the doors. The first patient was a man in his 50s, respiratory distress, chemical burn to the face and upper chest. His breathing had that wet sound, pulmonary edema, fluid filling the alveoli. He was standing, which meant he could still oxygenate enough to maintain consciousness. That would change in minutes. Sarah was already moving him to Bay 1, already assessing. Capillary refill normal, pulse rapid but not shock level, blood pressure elevated from stress and hypoxia. The burn pattern was consistent with exposure to a solvent-based chemical, probably something chlorine-adjacent based on the damage pattern. Respiratory exposure, not systemic poisoning. Yet, okay, sir, my name is Sarah. We're going to get oxygen on you right now, and we're going to make sure your lungs don't get worse. Can you tell me your name? David. His voice was hoarse. The vocal cords were inflamed. David, we're going to put a mask on you. It's going to feel heavy, but it's helping you. Can you do that? She had the high-flow mask ready, 15 liters per minute, the maximum the delivery system could provide without intubation. She placed it over his face with practiced efficiency and turned to Dr. Reeves, who was assessing the second patient in Bay 2. David, 50s, respiratory distress. Strider, chemical exposure to face and upper airway. I'm going to monitor for airway compromise. He needs intubation prep if he deteriorates in the next 10 minutes. She wasn't asking. She was informing. The difference was subtle but absolute, Doctor. Reeves looked at her for a fraction too long. Not confusion, but recalibration. First-month nurses didn't predict intubation needs. They followed orders. Set up the equipment, he said. Keep him on high flow. We'll watch his SATs. Sarah was already pulling the intubation kit. Laryngoscope, endotracheal tubes in multiple sizes, the difficult airway setup, the backup video laryngoscope. She laid them out in the sequence they'd be used. Then she grabbed 2 units of 4 fluid from the warming cabinet and set them on the stand. Chemical exposure meant systemic shock was coming. Even if the respiratory system was the immediate threat, the second ambulance was arriving. More sirens. More voices outside. Doctor. Reeves was moving to the ambulance bay. Rachel was in Bay 2 with the second patient. Margaret was doing rapid triage. Send this one to fast track. Hold this one for secondary assessment. Sarah was monitoring David's oxygen saturation, 88%. Should be higher. The mask wasn't enough. She called out, David's SATs aren't climbing. We need to intubate. Not yet. Dr. Reeves called back from the bay. We wait for his trend. Sarah understood. You didn't intubate unless you had to. Intubation meant commitment. Meant the patient couldn't protect his own airway. Meant he was ours now. Completely. She watched the monitor. 87%. 86%. SATs dropping, she said, her voice level. Doctor. Reeves was coming back through the door with the third patient. Woman, 30s, respiratory complaint, skin burns to arms. He saw David's monitor at the same instant Sarah called it. Set him up, Dr. Reeves said. Sarah was already moving. She positioned David on his side, got 2 IVs in, 1 in each arm, 18 gauge, and pushed rapid fluid bolus while simultaneously preparing the intubation field. Position. Pre-oxygenate. Prepare equipment. She was thinking in layers. David needs intubation now. Rachel's patient in Bay 2 needs assessment and probably fluids. Third patient needs workup. Blood bank will be depleted fast. Pharmacy needs to know we're using multiple sedation protocols simultaneously. The ER is about to be overwhelmed. 2 amps of etomidate, she said to Rachel, who was moving past. And succinylcholine. We need rapid sequence. Rachel was already grabbing medications. She didn't question Sarah's dosing. She just moved. Doctor. Reeves was drawing up the medications when Sarah positioned the laryngoscope. She was going to let him do the intubation. She was a nurse, not a doctor, and in the hospital hierarchy that mattered, but she was controlling the field anyway. Equipment in place. Suction positioned. Backup plan visible if the first attempt failed. Doctor. Reeves moved in. The technique was good, but not field efficient. He fumbled the blade slightly. Sarah was already there, steadying it with one hand while keeping tension on the patient's jaw with the other. The vocal cords appeared. The endotracheal tube slid through 0.10 seconds. Fast enough, she secured it, checked placement by auscultation, taped it down, and attached the bag valve mask. She was pulling vitals. Heart rate 112, blood pressure 156/98, oxygen saturation climbing. Secured, depth 21 at the teeth. We have good breath sounds bilaterally. She'd given the technical briefing without being asked. That wasn't first-month nurse behavior either. The third ambulance was here. 4 more patients coming through the doors. 2 walking, 2 on gurneys. One of the walking patients collapsed 5 feet into the bay. Sarah was moving toward him when Margaret grabbed her arm. Bay 4. We need assessment fast. Sarah moved. The 4th patient was on a gurney, respiratory distress, but controlled. Different presentation. This one's chemical exposure was systemic, not just respiratory. Elevated heart rate. Dropping blood pressure. Pupils dilated. Muscle tremors. She was thinking organophosphate. Not chlorine. Different exposure site. Different mechanism. Atropine. She said to Rachel, who was following her in. And we need continuous cardiac monitoring. This isn't just respiratory. He's in cholinergic crisis. She was calling it before the physician even assessed him. That's when she felt it. The presence. Movement at the edge of the trauma bay. One of the Admiral's operatives had left his post at the corridor. He was standing just inside the bay entrance, watching, not supervising, not interfering, just watching that Sarah's hands didn't falter. She was getting a second 4 in, pushing fluids, preparing the atropine, but she registered his presence, registered his attention, registered that he'd moved from his position because he'd seen something that changed his assessment of her. She glanced at him for less than a second. Their eyes met. She saw recognition there, not shock, but confirmation. He knew what she was. She turned back to her patient and kept working. The clock showed 1:47 a.m. 13 minutes had passed since the first ambulance arrived. 8 patients were in the ER. 6 needed acute intervention. The medication cart had been depleted faster than she'd predicted. The blood bank had already been called twice. And somewhere in the controlled chaos, 2 separate hierarchies had collided. The military hierarchy, watching from the corridor. The hospital hierarchy, moving through their protocols. Neither of them understood what they were actually seeing. Sarah had been running the mass casualty response for exactly 1 hour. 14 patients were now in the ER or in holding. 12 were critical or urgent. The attending physician, Dr. Marcus Webb, trauma specialist, 15 years in, was in surgery with a patient who needed immediate vascular repair. Dr. Reeves was managing the ER floor with Margaret and Sarah, covering most of the actual clinical decisions because there wasn't time for supervision. The medication cart was 60% depleted. The blood bank had 8 units of O-negative left. They had 6 more patients in the pipe who would need blood. The math was simple and terrible. Sarah was in Bay 7, managing a patient with deep chemical burns to the abdomen and lower extremities. The burns were 3rd degree, severe enough that fluid replacement couldn't save the tissue. It could only buy time for surgical intervention. She'd already started the first unit of blood. She was calculating the second when Rachel appeared at the door. Blood bank is calling. They want to know if we're using all the O-neg or if some patients can be moved to type-specific. They only have 8 units in stock right now. More incoming, but it's 40 minutes out. Sarah's patient was getting the second unit. 2 more patients in acute bays needed transfusion to maintain perfusion. 1 more was arriving by ambulance, ETA 4 minutes. Another was in fast track waiting for labs that would determine if they needed blood. 8 units. At least 6 patients needing transfusion. The math didn't work. Sarah stepped out of Bay 7 and went directly to the charge station. Margaret was on the phone with pharmacy. The Admiral's operative was still visible in the corridor entrance, still watching. Sarah picked up the phone that connected directly to the trauma surgeon's office. Dr. Webb wasn't there. He was in OR. But his surgical resident, Dr. Patel, was prepping the next case. Dr. Patel. Sarah Chen, ER. I need to redirect a patient. The one in Bay 6, chemical burns, abdomen and bilateral lower extremities. Depth is full thickness, estimated 30% total body surface area. What's his status? Vitals stable on fluids. That's good. Neuro intact. No respiratory component. But we're going to deplete the blood bank if he receives massive transfusion protocol now. His tissue is dead. Transfusion is a delay, not a cure. There was silence. Dr. Patel was smart enough to understand what she was saying. Don't transfuse this patient until he's on the operating table where hemorrhage can be controlled. What's your recommendation? He asked. Surgical hemostasis first. Get him to or control the bleeding at the source. Then transfuse. We run dry in 20 minutes if we try conventional protocol. We save the bank if we shift vectors. Another silence. Longer this time. Get him typed and cross-matched. I'll take him next. 30 minutes. Sarah hung up and turned to Margaret. Base 6 patient is going to pre-op. Minimal fluids until surgical hemostasis. We're redirecting his blood allocation to the incoming acute cases. Margaret's face shifted, understanding the decision, understanding what it cost. The patient in Base 6 would suffer more because his fluid replacement would be restricted. But 3 other patients would have a chance at survival instead of everyone bleeding out together. Okay, Margaret said quietly. I'll notify the team. That's when the attending who'd been working the fast-track station came to the central desk. Dr. Sarah Huang, internal medicine specialist covering the ER overflow. She'd been directing the less critical patients to waiting areas, managing observation cases, coordinating with admitting. I saw the note on Base 6. Why is he being restricted on fluids? Sarah turned to face her. This was the moment where hierarchy mattered. Dr. Huang was the attending. Sarah was a first-month nurse. But Sarah had made the decision and Margaret had sanctioned it. Blood bank depletion, Sarah said. Her voice was steady, clinical. 8 units remaining. 6 patients with active transfusion needs. Mathematical impossibility to meet demand using standard massive transfusion protocol. Base 6 patient has dead tissue requiring surgical debridement regardless. Transfusion before hemostasis control is inefficient. Redirecting his allocation to patients with viable tissue and active bleeding. Dr. Huang blinked. That wasn't nursing assessment. That was surgical thinking. That was triage prioritization that belonged in an operating theater, not an ER intake evaluation. Who made that decision? Dr. Huang asked, but she already knew the answer from the way Margaret was standing. I did, Sarah said. On medical grounds. Dr. Patel approved the surgical protocol. Dr. Huang looked at Margaret for confirmation. Margaret nodded. Then Dr. Huang looked at Sarah differently. The way you look at something you've been assessing incorrectly. You've done this before, she said. Not a question. Triage in mass casualty situations requires mathematical prioritization, Sarah said. It was true. It was also deliberately non-responsive. No, Dr. Huang said. Not triage assessment. Resource allocation under pressure. The language. The thinking. You've done this. Sarah didn't answer. She turned back to review the labs on her next patient. But she felt it. The moment when invisible became visible. When the careful construction of being a new nurse, being unremarkable, being just another first-month graduate started to crack. The Admiral's operative was still in the corridor. Still watching. And now Sarah was certain. He'd moved from his post not because he'd recognized her competence. He'd moved because he'd understood something specific the moment she'd secured David's intubation with a technique that was too clean, too practiced. The operative stepped back into position at the corridor entrance. But now he was looking at his watch, calculating something. Sarah understood the calculation. He was measuring time until the Admiral needed to know that his courier's security had just become secondary to something larger. The ambulance with the 5th critical patient arrived at 2:23 a.m. Respiratory distress. Systemic chemical exposure. Blood pressure dropping. Shock level lactate. Sarah was moving toward the bay when Dr. Huang appeared beside her. I need to know who trained you, Dr. Huang said quietly. Medical school, Sarah said. Then clinical rotation. Standard curriculum. It was a lie. And Dr. Huang knew it. But she also knew that asking the real question, who were you before this, wasn't a conversation to have in the middle of a mass casualty response. The patient coded at 2:47 a.m., full cardiac arrest. Sarah called the code. Sarah called medications. Sarah coordinated compressions with the precision of someone who'd done it in conditions far worse than a climate-controlled R.30 seconds of perfect rhythm. Then rhythm recovery. Then stabilization. The patient was alive. Sarah stepped back from the bed, breathing controlled, hands steady, and didn't look at the Admiral's operative who was no longer pretending to watch the corridor, but he was watching her. The clock showed 2:51 a.m. 9 minutes remained in the second hour. Sarah was in Bay 8 finishing a secondary assessment on the patient she'd redirected from massive transfusion. His condition was stable, his breathing controlled, waiting for his 30-minute surgical window. The ER had reached a strange equilibrium. Still crowded, still critical, but no longer escalating. That's when the monitor alarm came from the private corridor, not loud, not frantic, just the steady, urgent beeping of a patient in cardiac distress. The Admiral's operative at the corridor entrance moved immediately, not panicked, but decisive. He keyed his radio. Sarah heard only 2 words come through. Patient down. Doctor. Reeves was the closest physician. He started moving toward the private corridor. Margaret was behind him. The Admiral's security personnel were blocking the entrance, but they stepped aside for the medical team. Protocol. Even in a classified situation, a crashing patient was everyone's responsibility. Sarah was already moving too. Not because she was assigned, because she was reading the scene the way she used to read rooms full of casualties in a different life. One patient crashing, one operative calling it in, one admiral stepping out of Bay 12 with the controlled frustration of someone watching a plan fail in real time. She was in the corridor 2 seconds behind Dr. Reeves and Margaret. The admiral's courier was on the gurney, already in full arrest. Monitor showed ventricular fibrillation. No pulse check needed. The rhythm was diagnosis enough. The sedation, the stress, probably underlying cardiac pathology they didn't know about. The patient's body had decided this was the moment to stop. Crash cart. Dr. Reeves was calling. I need compressions. The operative was already starting chest compressions, not medical grade, but functional. Strong rhythm. 30 compressions, counting it out loud in the style of someone trained in emergency first aid. But it was wrong. Sarah saw it immediately. The compression depth was too shallow. The patient was sedated, his muscles were relaxed, his ribs were movable, but the operative was compressing to the level of conscious resistance, not actual need. It would move blood, but not enough. Not the pressure needed for a sedated patient. And they had maybe 90 seconds before irreversible brain damage started. Dr. Reeves was positioning for intubation. Margaret was getting the crash cart. No one was adjusting the compression depth. No one was thinking tactically about what worked versus what looked right. Sarah made the calculation in 1 second. Stay back and watch the system fail, or step forward and reveal everything. She stepped forward. I've got compressions, she said. It wasn't a request. The operative looked at her. So did Dr. Reeves. So did the Admiral. Sarah was already positioning herself. Hands on the patient's sternum, angle correct, depth assessment complete. She started compressions at full intensity. Hard. Fast. The way you had to do it when you were working a patient in a field environment where the next resource might be 45 minutes away. 120 compressions per minute, she called out. Airway management when ready. 2-minute cycle. She wasn't speaking like a nurse. She was speaking like someone running a code in a combat zone. Dr. Reeves had the airway positioned. He was moving the intubation equipment, slower than Sarah had done it with David. A good physician, but he was working inside hospital protocol. She was working inside survival imperative. Compressions are too deep, Dr. Reeves said, but he was already seeing the monitor. The compressions were generating better perfusion than the operative had. The waveform was stronger. Sarah didn't respond. She was counting. 60 compressions. Maintaining pressure. Blood flow to the brain. Keep it going. Airway, she said at 62. Dr. Reeves was moving. The intubation took 18 seconds, longer than ideal, but acceptable. Tube secured. Ventilation started. Sarah felt it. The moment the patient's chest was rising from the bag valve mask instead of her compressions. She shifted rhythm, maintained pressure, moved into the cycle. The Admiral was standing at the edge of the bay. Just watching. Not interfering. Just watching his patient get coded by a first-month nurse who was running it like she'd done this 100 times because she had. AP, Sarah said. Margaret was there with the medication. For push. Immediate. The monitor showed asystole still, flat line. Dead rhythm. But there was electrical activity underneath, just not organized into function. It meant the heart hadn't completely checked out. Just needed the push to restart. 2-minute mark. New rhythm check, Sarah called Dr. Reeves looked at the monitor. Still flat. Compressions continue, Sarah said. She was counting again. The rhythm of it was familiar. Meditative and urgent at the same time. One hand driving down. The other hand braced. Pressure. Release. Pressure. Release. The patient's chest was responding, ribs moving, sternum compressing, blood moving through vessels. 90 seconds. She felt it. A subtle change in resistance. The defibrillator was picking it up too. The flat line was developing a tiny oscillation. 1 minute. New rhythm check, she called. The monitor showed sinus bradycardia. Weak, slow, but organized. The heart was trying. Sarah maintained compressions, gentler now, supporting rather than driving. Blood pressure cuff came on. 62 systolic. Low, too low, but present. Get me 2 units of blood. Lactated ringers wide open. And we need transport to ICU right now, Sarah said. She looked at the Admiral for the first time. Your patient is in cardiogenic shock. He needs a monitored bed and probably a cardiologist consult. He's alive, but he's critical. The Admiral's face was unreadable, but his operative was no longer maintaining distance. He was stepping closer, looking at Sarah with something between recognition and something that looked like appraisal. Who are you? The Admiral asked. Not angry, not accusatory, just a direct question that meant he already knew the answer. Sarah didn't respond. She was maintaining compressions as the ICU team arrived to transport the patient. She was moving with the gurney, maintaining rhythm, maintaining pressure, not breaking the connection because breaking it might mean the rhythm would break too. The Admiral followed them toward the elevator. Ranger School, 2017, he said, not asking, stating. Sarah looked at him for one moment. Just one. Sir, she said that it was confirmation. It was the end of concealment. It was the moment when she'd chosen a stranger's life over her own invisibility and paid the price of being seen. The elevator doors closed. The Admiral stayed behind on the 3rd floor. Sarah rode up to ICU with a patient she'd just brought back from the dead. The clock showed 3:14 a.m. The courier was stable. Barely. Cardiogenic shock from a pre-existing arrhythmia that no one had disclosed to the ER. The ICU team was still tuning medications, running continuous monitoring, the controlled panic of keeping someone alive who almost wasn't. Sarah had returned to the ER at 3:34 a.m. The mass casualty response was winding down. 13 of the 14 patients were assigned to beds, to surgery, to observation. The ER was moving from crisis management back into the controlled rhythm of trauma management. Breathing room. Sort of. She was in Bay 4, updating the chart on the patient with organophosphate poisoning, when she heard the footsteps. Deliberate. Single person. Moving with the kind of precision that meant this wasn't a casual walkthrough. The Admiral appeared at the bay entrance. He was alone. His operatives were positioned elsewhere, one in the private corridor still, one somewhere in the main ER flow. The Admiral himself was just standing there, looking at her with the expression of a man checking a calculation and finding it correct. Bay 9, he said quietly. Can we talk? Not a request, but not an order either. Just the phrasing of someone who understood that Sarah had the right to refuse. She finished typing the chart entry, the professional thing to do, the thing that meant she wasn't running from this conversation. Then she closed the computer and looked at him. Yes, sir. Bay 9 was empty. The Admiral stepped inside, and Sarah closed the curtain behind them. The bay had a monitor, a bed, a crash cart, and complete privacy. He sat on the edge of the bed. She stood, maintaining distance and position, not hostile, just tactically aware. 2017, he said. It wasn't a question. Ranger School. That was your cohort year. Yes, sir. You were attached to my task force. April through October. Eastern Theater. You were the senior medical support for Charlie team. Sarah didn't correct him. She didn't embellish. She just held position. You had 43 field recoveries. 1 Kia from your team. Sergeant Webb, IED, not your fault. You walked 3 kilometers carrying 180 pounds of wounded operator back to extraction point. Infection set in. You kept him alive until surgical intervention. He's still active duty. Still has a leg. The Admiral paused. He was looking at her the way commanders look at soldiers they've documented but never fully understood. Then you went home. You left the teams. Submitted your discharge papers 6 months later. Said you were pursuing higher education. We all thought you'd be a PA or a physician. Instead, you became a nurse and disappeared into civilian infrastructure. Sarah still didn't speak. Tonight, the Admiral continued. You ran a code on my patient with a proficiency that doesn't come from nursing school. You managed a mass casualty incident with resource prioritization that belongs in a military field hospital, not an ER. You read that operative's compression technique and corrected it without hesitation. And you did all of that while pretending to be a first-month graduate who just happened to be in the right place that he stood up. His height was intimidating, but his voice stayed level. So I'm going to ask you directly, why are you working as a nurse at St. Michael's ER on a Tuesday night when you could be running medical operations for the Department of Defense? Sarah met his eyes. The answer was complicated. The answer involved things she'd seen in those 6 months. People, operators, soldiers, civilians caught in the crossfire, who depended on her medical knowledge and nothing else. Who'd lived or died based on whether she could set a line faster, think clearer, prioritize better. 6 months of that was enough. 6 months of understanding that her value existed in the abstraction of survival metrics and tactical necessity, not in the person she was. Because I don't want to be the person I was, sir, she said. I don't want to be assessed by my utility in a crisis. I don't want to be the resource that gets deployed when people are dying. I want to be the person who shows up because it's her job and then goes home and doesn't carry it. And how's that working out? The Admiral asked. His tone wasn't mocking, just honest. Sarah didn't answer because they both knew the answer. It wasn't working. It had never worked. You don't spend 6 months functioning as a combat medic and then pretend it didn't rewire your brain. You saved 15 patients tonight, the Admiral said. Without backup, without authorization, without any framework except what you knew and what you could do. That's not a first-month nurse, Sarah. That's a professional soldier operating inside a civilian institution. I know, Sarah said quietly. Do you? The Admiral stepped closer. Because I don't think you do. You think you can wall off who you were and exist as someone different. But what you did in that mass casualty situation, the mathematical prioritization, the compression technique, the medication sequencing, you can't teach that in a hospital. That's operational experience. That's what you bring that nobody else in this building brings. With respect, sir, I don't want to bring that. I want to be a nurse. You are a nurse, the Admiral said. You're also a former ranger with combat medical training who chose to leave and now finds herself running combat protocols in a civilian emergency room because that's what crisis demands. You can't split the difference. You can only choose which version shows up when it matters. Sarah felt the weight of it, the decision she'd made when she submitted her discharge papers, the assumption that she could wall off that 6 months, the hope that there was a version of herself that could exist separate from what she'd learned, what she'd done. The Admiral had just confirmed what she already knew. There wasn't. So what now, sir? She asked. The Admiral was quiet for a long moment. When he spoke, his voice was different. Quieter. The voice of a commander speaking off the record. Now you finish your shift. You document what you did tonight in the medical record exactly as it happened. You don't minimize it. You don't hide it. Dr. Webb sees what you did. Dr. Huang sees what you did, and they understand it. Because they need to understand it. He paused. After that, you go home. You rest. And you decide whether you want to be a nurse who happens to have military medical training or a soldier who's working in a hospital. But you stop pretending you're something in between. That path doesn't exist. He turned to leave, then stopped at the curtain. For what it's worth, Chen, your decision to leave the teams was sound. We don't need more operators who can run combat medicine. We need people who understand what the cost actually is. That makes you rare. He stepped out of Bay 9. Sarah was alone in the empty bay with the monitor and the crash cart and the weight of being seen. The clock showed 3:52 a.m. 15 patients were stable. All of them. The patient in ICU with cardiogenic shock was holding on marginal support, but holding. The chemical burns were in surgical recovery. The respiratory exposure victims were oxygenating well enough. The system had held. Sarah was at the central station finishing her charting, not minimizing what she'd done. Not hiding it, just documenting it in clinical language, interventions, outcomes, times, decision rationale. The medical record was clear. Anyone reviewing it would see exactly what had happened and the sequence of decisions that made it possible. Dr. Huang appeared beside her twice while she was working. Just appeared. Read over her shoulder. Didn't comment. Just confirming. Just witnessing. Dr. Webb came out of, or at 4:34 a.m. He went directly to the central station, read Sarah's notes on the patient she'd redirected from massive transfusion, and then looked at her with the expression of someone recalculating someone else's entire existence. That was field medicine, he said quietly. Yes, sir, Sarah replied. He nodded once and walked away. The Admiral was in the corridor at 4:52 a.m. Margaret was writing discharge notes. Rachel had gone to the break room. Dr. Reeves was reviewing imaging. The ER was settling into the strange peace that follows a crisis. The adrenaline was gone. The work remained. The only thing absent was urgency. The Admiral caught Sarah's eye from across the charge station. Not a gesture, just a look. Then he turned and left through the private corridor with his operatives trailing behind him. The courier would be ICU's problem now. The crisis was over. The Admiral was leaving. That was it. The recognition. The moment of being seen. And then departure. Sarah clocked out at 5:03 a.m. The parking garage was empty at that hour. Just her car, and the weight of a shift that had lasted 6 hours and felt like 6 years. She drove home in silence. The radio stayed off. The roads were empty except for early shift workers and insomniacs. Her apartment was a studio. Sparse. Bed. Couch. Kitchenette. No photographs. No art. Military clean. The kind of place that could be abandoned in an afternoon without leaving trace. She showered. Changed into civilian clothes. Set the alarm for 0600. Tomorrow was a regular shift. 8 hours. Standard ER volume. No mass casualty. No Admiral. No operators watching from corridor entrances. Just 15 patients who wouldn't know who saved them. Who would remember the doctors and nurses who were visible. Who would never know that the quiet girl in the corner had made decisions that bought them their lives. Sarah lay in bed and stared at the ceiling. The Admiral knew her name now. He knew what she was. He'd seen her with the mask off, just for 15 minutes. And then he'd walked away and left her to figure out what came next. That was the wait now. Not invisibility, but visibility that came with no choice attached. Tomorrow she'd be a nurse again. The routine would settle. The crisis would become a story told at shift change, eventually forgotten. The Admiral would return to his offices and his classified operations. His courier would recover or not recover. The world would keep turning. But something had been seen, and seeing couldn't be reversed. Sarah closed her eyes and didn't sleep. The alarm would come at 0600. The shift would start at 0700. The rest of it. The choice between who she was and who she pretended to be. That would come later. For now, there was only the dark and the certainty that she'd chosen correctly and paid the price of that choice. That had to be enough.